The goal of population health in an integrated care system is to sustain and improve the health and well-being of people and populations. And at the personal level, we only create value with health and care services one person at a time. It's important to keep that in mind. We also need to keep in mind that population health management should have a strategic fit to the locality in which you're working. By that I mean you need to understand the assets and the challenges, the unique challenges faced in a particular context. There also, in addition to a strategic fit, you need to have a strong strategic intent. And the purpose of the strategic intent is to set a realistic but lofty goal, one that people can rally around, one that can give people a purpose for working together as a team. Finally, because of this notion that you create value one person at a time, it's really important to recognize that the learning front end of an integrated care system that is trying to improve and sustain population health is at the front lines. We have the most to learn from the people we serve, particularly when we're dealing with the very different contexts in which they live their lives. I think it's also important to think about how we learn and how we learn from variation. Variation is all we learn from. Sometimes we can control it, sometimes we can't, we just observe it, but it is what we learn from. So it's worth asking and understanding so you can communicate to others how we learn from variation in outcomes and costs. I would submit that we learn from variation in outcomes and costs by making visible the underlying processes and look at which variable processes are associated with the good outcomes and the lower costs and which with the bad outcomes and the higher costs. If we don't make visible those processes, in other words, what is the process of delivering surgical intervention, or what is the process of delivering care and co-management to somebody with multiple chronic conditions? If we don't make that visible, we don't learn. The second question is, how do we learn from variation in the choices that are made by seemingly similar patients or on behalf of seemingly similar patients? And of course, those different choices add up to different per capita rates in different geographic regions. I would submit that just as we learn from variation in outcomes and costs by making visible the underlying processes, we learn from variation in choices and rates by making visible the underlying preferences. In doing that, we hold up the warranted variation while we reduce the unwarranted variation. A third question that I think is important for people to ask when you think about the wonderful ambition of the 5-year forward view when it was published in 2014 is, how do we increase the opportunities we have to really make a difference with population health management with integrated care teams at the front lines? And I would submit that we do that by better understanding what the patient needs with regard to their social care, what it is that brings them to the A&E frequently or brings them to the GP surgery frequently. And the opportunity there is to avoid silo thinking within healthcare that has us delivering high cost, high risk interventions that fail to meet basic needs while they exceed the patient's wants, when the basic needs could be met by something in the community at low cost and low risk. An example that I like to use is the frail elderly woman whose banister is broken and she can't get down the steps to see the postman every morning and therefore feel less lonely. She might not have time to explain all of that to her GP. An image is taken, the osteoarthritis has gotten worse. She's sent to see a consultant, and soon she's having her hip replaced. Integrated care systems at the front line, manifest by integrated care teams, give us the opportunity to avoid replacing hips rather than fixing banisters.